Good morning and welcome to the University of South Florida Global Health Conversation Series. My name is Zach Porterfield, and I'm a physician scientist at the University of Kentucky in the Division of Infectious Diseases, Immunology, and Otolaryngology, and a practitioner of global health. It is my sincere pleasure to welcome two of our speakers today to discuss global health partnerships. Apologies. I want to start by introducing Dr. Lindokuhle Sibiya, who is the Chief Specialist and Head of the Department of Otolaryngology at the University of KwaZulu-Natal. She completed her ENT training at the University of Cape Town and a Master's of Medicine at the University of Pretoria, as well as an MBA at Oxford University. Additionally, Dr. Julia Toman, who is currently an Associate Professor of ENT at USF, a Director of the Facial Cosmetic and Reconstructive Surgery Center, and completed her ENT training at Yale University and facial plastic surgery training with Ed Ferry at the University of South Florida. These two individuals are ones that I've had the privilege of working with for the past 8 years on global health projects, and truly are voices for global health and leaders in their respective fields. And I invite everyone to listen carefully and learn some lessons about global health partnerships, and specifically how to develop equitable relationships in global health. Anyway, Dr. Sibiya, Dr. Toman, thank you very much.
Thank you.
Thank you so much, Dr. Porterfield, for that kind introduction. I'll just go ahead and share my screen here. Has my presentation showed up?
It has, thank you.
Excellent. Okay, so today I have the great pleasure and privilege of having this conversation with a partner in crime, Dr. Sibiya, and I'm so excited to share our experience in using research as a catalyst for equitable international collaboration. So certainly, while the three of us get the opportunity to share with you our experiences and the journey that we have been on, this is certainly not just the three of us. These endeavors take innumerable inputs, and this list is certainly not exhaustive, but speaks to the fact that this is a large community and a large network of people that really make these sort of partnerships a success. But I'll take you back to the beginning of at least my journey on the side of this. And so it really started with two unlikely colleagues marrying together ENT and infectious disease. My colleague, Dr. Porterfield, had been working in a rural area in South Africa that had a long partnership with Yale University practicing HIV and TB medicine. And he came back with a question: why are there all these draining ears? What is going on? What is driving this? And so as part of an initial effort, we decided that we would build on the back of what had already been a well-established relationship and do a small clinical experience based on a research question of why are there all these ear infections in this particular community? And so we saw a huge need here. There's 65 to up to 330 million people affected by chronic suppurative otitis media. Prevalence as high as 20% in children in some populations at risk. And there's a huge risk of developing hearing loss. So if you can sort of figure out why these things are happening, maybe we can affect change. And so we began sort of humble beginnings in a small infectious disease clinic in rural KZN. And really it wasn't just the research, but it was also an assessment for the role of a partnership. And so while we use this research focus of use of routine culture to improve treatment of chronic suppurative otitis media in a rural setting, this was also a needs assessment of, are there other partnerships that we can form to be more effective? We certainly had no intentions of going in and sort of fixing a problem. It was, who else is playing in this area? We have identified this small need in this small corner where we've had a partnership, but this is a larger issue, and how do we engage on that? And so really what started out as a small clinic within the infectious disease department, and we saw lots of different disease pathology, really became a larger goal of engaging with our South African partners in expanding access to care. And so where this really launched was in forming this partnership with the University of KwaZulu-Natal in attempting to identify areas of cohesion. Where could we work together for improvement in clinical care, in research infrastructure, and in educational exchange for the betterment of both parties. And so a partnership was formed, looking at clinical care, education, and research infrastructure development. One of the early areas that we identified as a need, it was identified by our South African partners as a need, was early cancer detection. And there was this, people present late to care, they have end stage disease in a system that is faces care challenges. Wouldn't it be better if patients presented earlier in their disease when they could have only a surgical management option? They didn't need any additional therapy like radiation or chemotherapy. They didn't need perhaps as extensive a surgery, perhaps cutting down on time spent in hospital, and complications, which might be a burden to manage in an already stretched system. And so we focused on early cancer screening, and trying to better educate both ourselves as a community of otolaryngologists, as well as providers in the community about head and neck cancer. And so that was identified as a major area where we could affect change. And part of that included, and probably most importantly, included engagement of stakeholders. That included providers at some of the regional hospitals, that included Department of Health, that included industry, and engaging these people in a conversation surrounding head and neck cancer. And then, as I mentioned, we had some educational endeavors. So trying to improve access to educational opportunities. We have the benefit in the US of training with subspecialists who are subspecialists who are subspecialists in different fields. And we also get the opportunity to travel to conferences that are within the United States that are offered on a routine basis. But especially when you have problems with, if you're the only provider to a large catchment area, if you go off to a conference, sometimes there's some difficulties in providing coverage, which I think Dr. Sibiya can speak to much more clearly than I can. But what we were asked was, can we bring some educational opportunities to these providers to build upon their already phenomenal skill set? And so all of this sort of catalyzed together, where we identified 3 pillars for exchange. One was education, increasing educational opportunities, but bilaterally. Participants from the US participating in the exchange in South Africa learned a huge amount about disease processes that maybe we don't see as much in the US, or other ways to care for them. That was really beneficial. And my hope is that our South African colleagues learned a little bit from our expertise, and it really became an exchange of information because we're truly learning from each other. Research infrastructure was identified as a key area where there was a lot of synergy. And this whole thing started with a small research project in rural South Africa, and really using that as a catalyst to drive answering questions regarding clinical care in the communities being treated by these providers. But where we could come in was maybe providing some infrastructure development, how do you ask a question? How do you design a research endeavor that then allows you to answer that question and affect change in your own population? And the third component, probably the smallest, has been clinical care, because the truth is that our South African colleagues know way better than we do how to provide care in the communities they provide. And I've learned an incredible amount from having the opportunity to work with them about some of the disease processes that they manage. And at that, I'll turn it over to Dr. Sibiya.
Thank you very much. Will you do some screen scrolling for me then?
Yes.
So, South Africa, for those of you who haven't had a chance to be here, is a country of many deep contrasts. We have a very tortuous legacy of apartheid and division and inequitable development. And that lies in this amazing country where you have everything from deserts and game reserves to skiing and some of the best diving in the world. We have 10 World Heritage Sites. The USA has 24. We're about 2 times the size of Texas, I think. USA as a whole is about 8 times the size of South Africa. And yet we offer so many different things. For example, this little town where I was working, in fact, when I first met the US team, an hour north of there is this amazing dive site called Sodwana. It's a World Heritage Site. It's about 1/10 of the area of the Great Barrier Reef and has the same number of fish species. So whilst we have all of these things available, the contrasts mean that we still have children who have to cross a river simply to get to school. So within that context, we have our healthcare system, which also, because of our legacy, if you can move on, our legacy provides incredibly highly trained specialists, but far too few for too many. Within our population group, we have fewer than 300 ENT specialists, and of those, less than 40 are actually serving within our public sector. Within the province that we speak of now, KwaZulu-Natal, there are anywhere between 6 to 9 ENTs because life happens and people move on or move out. And the population itself is about 11 million. Our training is incredibly high quality, but opportunities for training are very scarce. I think there are fewer than 30 residents in the country as a whole, with a throughput of about 5 per year, depending on their level and where they are in their journey. So you've got the situation where you've got this incredibly high demand for clinical services and surgical services, but very few service providers. And some of that is actually a plus for us because you have quite a high clinical and surgical skills transfer process because the demand is so high. And often our guys pick up their surgical skills quite quickly. But our scope of work and our focus is very much driven by our disease burden. And so there's also a very high demand for doctors from South Africa into other parts of the world, in particular Canada, New Zealand, and Australia. And there's also active recruitment into the private sector, where the workload and the lifestyle are far more conducive. So back when I first met the US team, I was working in a small town in the northeast coast of South Africa, in an environment where you can move on, where I was the only full-time ENT practitioner in that service, with one half, part-time specialist assisting, servicing a population of just over 2 million. It was very much driven by what the workload was. There were a lot late presentation, patients arriving with very advanced disease, and a lot of bottlenecking into our service because of our hierarchical system. And so ultimately, what ends up happening in an environment like that is you are spending a lot of your time putting out fires rather than really exploring the scope of capabilities and, in fact, even needs of that environment. So very little time to focus on outreach, on research, even on developing areas of niche expertise, so subspecializing. So usually when you're in a situation like that and an international collaborator reaches out to you, what usually happens is you have this really, really imbalanced research agenda. And this is a recent publication, actually, that's just come out, if you can move on, where there was a consensus statement that was, I think it was published this month, in fact, around equitable authorship in the publication of research. Now, of course, while this speaks to publication, ultimately research begins on the ground with these collaborations and relationships. And what this very dynamic graphic shows is how journals often drive donor funding, which feeds into global health agencies, but somehow that is also diverted largely towards your high-income countries and their research agendas and capabilities. And so you get this unequal flow of knowledge and capital between these partners. And so with this power differential, you can sometimes have quite conflicting priorities, where people are leveraging relationships and expertise and funding to their own gain. So one of the things that was really key in working through a partnership was establishing where we could have shared objectives. Next slide. So Dr. Toman has already mentioned the head and neck cancer screening program. Now, where I was based, this was really significant. I had the problem of people arriving really late, did not have the capacity to be able to develop a really robust training platform and deliver that within the constraints of the workload I was facing at that stage, whilst our partners in the US were able to do that. And so we then had a need, we had people with the capability, and we were able to launch this. I think on that day, we were able to train just over 40 healthcare workers from more than 10 facilities in my drainage area, giving them the tools to then go out and train others within their own institutions. Now, if I remember correctly, this project, this head and neck cancer screening, didn't just take place in my center, where I was at that stage, but actually what became a little bit of a roadshow. And the workshop was presented at 4, if not 5, other units around the province. And so it was an amazing way to find that kind of real balance between the need and capabilities that actually worked for our communities as well. Next slide. So I think at the heart of it is really that, is identifying those overlapping research themes and goals. Some of our problems are very much the same. So one of the things, for instance, that we spoke about was the role of women in surgery. You can move on. The role of women in surgery. So the same problems in terms of transformation, diversity, and inclusion of women in these spaces that are traditionally very male exists across the globe. And those are challenges that we can tackle together and have conversations about methodologies that may have worked in other centers and other units. Through these exchange programs that have been mentioned, apart from fostering relationships and learning, there's been an opportunity to explore some of the contextual complexities that exist, not just in South Africa, but also in the US, and identify some innovations that might be transferable or modifiable for different contexts. You know, rural Kentucky, I'm told, has some of the very same problems that I have in rural South Africa. And so there's also been an opportunity to also support research. Our training model really, whilst we do have people who are really highly specialized, able to do really advanced surgeries, you know, open craniotomies, awake craniotomies while somebody plays the guitar, and all these things that are, you know, kind of world new, you know, endoscopic ear surgery and auditory brainstem implants. We have the capability to do a lot of that. However, there's very little scope to be able to expand that once you've specialized. And so the ability to get in people who are specialists, be exposed to a scope of practice that is relevant, but perhaps that we may be underexposed to, such as facial plastics, is really, really a great opportunity for our unit here. So as we move forward, I think COVID has given us an opportunity to stop, breathe, and kind of reevaluate what in-person collaboration is and what else might be derived from these partnerships. Within this consensus statement that had been released this month was a really interesting structured reflexivity statement, which was proposed as a method for journals to evaluate manuscripts that had been submitted from international partnerships to look at how these partnerships were equitable. But a lot of these questions that were posed within the statement are actually really great questions for us to pose to ourselves as well, each time we look at how to form collaborations. For example, you know, what is going to happen with the research that comes out of here? What happens to the patients, the participants on the ground? How are we managing this? What happens to the funds? What's the local priority for research? And how does the study that's being proposed or the collaboration that's being proposed speak to that? So together with Dr. Toman and others, we've had a chance to stop and look at what we'd like to look at moving forward. You want to take over from here, Dr. Toman?
Sure, happy to jump back in. So as Dr. Sibiya mentioned, we've had this opportunity with COVID to sort of reshuffle, reevaluate, and really hone the direction of our research. Because what we want to do is make sure that these research projects that we're engaging on moving forward are consistent with the questions still being asked. And I think it gets back to that sort of very busy slide that I showed, which is the need for this reiterative need assessment. And COVID was this great reminder to us that we needed to take a pause and think about what are our new research goals and how do they then drive both education as well as clinical care endeavors. And so head and neck cancer screening has always been sort of at the forefront. It was one of the first identified partnership areas. And so continuing efforts to improve screening, as well as early detection, to figure out how better way to link people into care. If they are identified, are there ways to strengthen the referral pathway, to create relationships, to provide manpower that perhaps provides a more depth of scope than can be provided by our colleagues who find themselves with a larger catchment area than I might, and sort of leverage some of that manpower of interested individuals to address these questions. Hearing health and ear health has been sort of the central thing that brought us all together, I think, and we all have a passion for hearing health. I'm often described as a very confused facial plastic surgeon. I'm so thrilled to bring my facial plastic skills to South Africa, but my heart in this is really in better hearing health, both identification and screening of children, but screening children without having a method to move forward and opportunity to engage and make a change is really critical. And so, yes, screening programs are critical, and we want to evaluate how can you effectively make a screening program in these very different environments, even within South Africa, let alone, around the world, in other parts of the US, et cetera. And that's another place where we learn a lot from each other. What has worked in South Africa? Can we engage that opportunity in other rural areas in the United States, which also suffer from some access to care issues, as well as ability to access intervention and, this disproportionate need that some of these individuals can have placing on the system? How can we intervene in research to help direct to and identify the problems sometimes, and bring attention to them in a way that allows us to make a change, to make a difference. And then this final area that we've identified has been HPV in the head and neck, both in head and neck oncology, sort of around the world. We've had this increase in the role of this viral cause of head and neck cancer, but how does this function within this population, which is disproportionately affected by HIV and TB and possibly other delays in presentation to care? And what can we learn from our colleagues, and what can we learn from what interventions have been undertaken in the US in an attempt to learn from each other, as well as respiratory papillomatosis, which I think I'll let Dr. Sibiya speak to, since it's something I don't see very often in my practice, but I've learned an incredible amount from my colleagues in South Africa.
Yeah, I mean, on the respiratory papillomatosis, we in our unit see probably 20 to 25 patients a month having to go into theatre for debulking of respiratory papillomatosis. Now, even within South Africa, that is disproportionately high. Our colleagues, for instance, at Red Cross Children's Hospital are taking 5 children a month to theatre. And for us, the burden is such that we have almost 600 clinic visits a year of children presenting with upper airway obstruction. And some of the challenges that we have in that regard, for example, is that we have children who have a really high rate of progressive disease, which spread into the respiratory system and the lungs, which is really, really significantly low in other parts of the world. And so there is something that we need to be doing here to look at why that is happening. And I think it's a wonderful opportunity for some research there that can really, really drive change and affect real quality of life improvements locally.
Absolutely. And it's the question that we struggle with here in the US as well, is how do we address respiratory papillomatosis? The thing is, in my registrar training, I saw 4 of these patients. And so understanding the disease that has been identified by our South African partners is something they want to focus on, right? There's something different happening in the environment, but the research that they can then produce informs the world and how we can better address respiratory papillomatosis as a disease process in other areas. And I think that our partnership, just to back up to hearing health, our partnership on this has led us to participating with the Lancet Commission and really allowing multiple voices to come to the table, speaking about their different experiences, because I know what my experience is in ear disease. Our colleagues in rural Kentucky know what their experience is with ear disease, but really having a global perspective in this partnership that we formed helps to not only define the question, as I mentioned, but also has led us us to think about what are some other research interventions that we can think about doing in both of our populations, and how to better address these and learn from each other.
Yeah.
So, we have a few concluding remarks, and then obviously we'll have some questions. But COVID allowed us to really rethink and redo a needs assessment. This all started with a research question, and it's expanded to multiple research questions. And I think, Dr. Sibiya, you said it best when, it started out with 2 universities that we brought together, but really it's allowed us over the last year or 2 years now to sort of think about what really is at the heart of it is this connection that you form. But in the sustainability aspect, we want enough people connected in that where we can engage on a departmental, a large scope scale, but enough people are involved that it's sustainable. If someone has to step out, if someone has a change, but you create this infrastructure and community that outlasts chairs, outlasts posts, outlasts family crises, et cetera, just continuing to work together. So I'll give you the final say, because you're always so eloquent.
Yeah, I think really when you start a partnership on the foundation of mutual respect, on a foundation where we are able to really honestly look at each other and say, here are your strengths and challenges, and here are mine. And how do we bring those together? Without this very traditional hierarchical imbalance, I think that lends itself to such a beautiful relationship that really can outlast all the things that life presents, because life is amazing in that it presents us with opportunities to move between different institutions, different roles, change our scope of practice and our interests. You're an otologist who's doing facial plastics, and yet at the core of it, the initial connections that have been formed can actually transcend a lot of that. And within that, you then are able to build a network, bringing in other people into a system that really has a really good, strong, ethically sound, equitable partnership at its base.
Well, it's been such a privilege to work with you over the last several years.
So on that note, I will thank you both for a fantastic presentation. This is really a remarkable partnership, and could not be more privileged to have been a part of it over these past many years. As a reminder, this webinar is being recorded. It will be available on YouTube. We have about 30 minutes for questions, and we already have some in the Q&A section. So please feel free to put questions into the Q&A, and I'll help address them to our presenters. One of the things that you've touched on, but I think is really a key question, is this idea of needs assessment, and what does that actually mean? What is this sort of role of this ongoing and open discussion? And then, practically, how do you do that? We talk about needs assessment sometimes as, let me use a formal construct to assess need within a community. And then there's sort of this more open idea of a needs assessment between 2 partners in a developing partnership. But how do you start those conversations? If what are the key elements in those conversations early on?
You want to take this one, Dr. Sibiya, or do you want me to give it a go?
I'll take it. I'll tell you. It's actually a really great question, because it really is more informal than people often think it is. But one of the things that I've done in my new role as the chair here is I've actually held biannual strategic sessions with each of the ENT leads. So we have about 8 service sites across the province as a whole. And every 6 months, we actually sit down and we have a strategic planning meeting. And we say, what are the things that are bothering you in your unit on the ground? And together, we then decide on what our priority areas will be and how we can prioritize that, because you really can't tackle everything. There'll be a long list if we really try to address everyone's challenges and all of the areas of concern. But being able to focus down to, look, here's what's really bothering me. A patient with cancer, I have the expertise to be able to operate on them, but they're arriving with me too late for me to intervene. So that is something that if I can get the patients to me sooner, I'm able to provide an intervention. So some of it really is driven by what we're seeing on the ground. I don't think we have a really formal framework that we utilize to establish that. And I think within pairing what we've established as our needs on the ground, and that's really not a me thing, it's all the stakeholders involved on my side as well, with what our partners and collaborators from other countries have looked into. I think that's where that matching then comes in. We're not asking for somebody to come in and solve all our problems. That's not at all the request. It's where is their alignment in both of our needs?
Yeah, and I think that when we first undertook our first project, we had this small research study, and then we had a needs assessment in the fact that while Dr. Porterfield had worked in South Africa on and off for a number of years at this point, we hadn't really engaged with any ENT providers up to that point. And a lot of the focus had been on sort of infectious disease types of characteristics. So part of the needs assessment in a sort of non-formal fashion was to run this small ENT clinic and sort of see the degree of pathology and sort of recognize the fact that, oh, well, the very smart people who already work here haven't stationed anyone out here because you eventually run out of patients to see. But it also afforded us with the opportunity through a few, honestly, chance meetings and encounters and introductions to create this other partnership, and then create through a series of mutually respectful conversations of, what are you looking to get out of this? Well, what are you looking to get out of this? What are you hoping to accomplish? What would you like to accomplish? Types of things. And I think being very open and honest has been critical in developing this partnership where you can really trust what the other person is saying. And, I have zero desire to come in and either tell you how to run a department, because I sure as heck don't know how to run one. Don't envy you that job, my friend. But I also all I have to say is well, this has worked for us. Maybe this might be a good screening idea. Maybe we can partner in this way. I have students who are very curious to understand more about what it's like to practice medicine outside of our ivory academic towers here in the United States. And so that is an enormous service that you do in our partnership to us, is that you have allowed our students to come and learn from you with your breadth of knowledge. And then, understanding that bringing subspecialists was an important endeavor. So I think that it's had a less formal structure, but it definitely has been engaged on these just mutually respectful, very open conversations about what the important aspects are for each of the players.
And to expand on that, we certainly are in a service-driven industry, and it is the populations that we serve that is at the focus of everything that we do. In these partnerships, how do you incorporate community perspectives? How do you make sure that the benefit here ultimately is for the patients and communities that you serve?
Well, I think that at least in our partnership, it's been driven by, asking the question, what are the challenges that you are facing? And here are some things that we might offer. Are these of interest? Because ultimately, yes, especially for head and neck cancer, we would love to have people seeing their local provider, them seeing a sore in the mouth and saying, off you go to the ENT specialist. Now, I can't go and sit in that primary care doctor's office and facilitate that, but what I can do is provide, some manpower to pitch up and teach the providers in these communities how to do a head and neck exam. And maybe people pitching up for it makes people excited about it, right? Having a bit of a to-do about things is really a nice way to sort of bring people together on a topic. And so that was sort of how I think we tried to focus in on the community, was identify the need and then together constructively come up with some interventions that might engage.
One of the really remarkable things that wasn't touched on is, Julia mentioned that I've been working in South Africa for some period of time. So I think we're at 21 years I've been off and on in South Africa. and had been interested in engaging, a programmatic approach to some of the problems that I was seeing. And it truly was meeting Julia in her residency training at Yale University. And so I frequently say, you've got to find a Julia, you've got to find a Dr. Toman. Because, really that was, an incredible, she brings an incredible amount of passion and expertise. And we were able to launch some programs from our side. And it really was the partnerships with our colleagues on the ground at University of KwaZulu-Natal, of which, Dr. Sibiya has been one of our long-standing partners and friends. But, I see that really it is finding those champions and finding those individuals who are passionate and able to give to a program and build it that are truly remarkable. There are some questions, and I'm sort of summarizing all of them into these questions. But, questions about how do you develop these programs? Where do you find the funding? How do you engage? Have you engaged industry sponsors? How do you balance private and public partnerships? But can you talk to sort of how did this develop? Who funded it? And how might you go about building a program and obtaining funding for these sorts of things?
Well, I can tackle it from my side first, and then I know that our South African colleagues have been very good at leveraging other mechanisms. As far as if from the U.S. side, how do you engage in these partnerships? Where do you start? Right? You want to do something good. You'd love to engage with someone. You don't want to do something wrong by accident, right? The literature is littered with sort of failed attempts, or perhaps history, as hopefully no one's publishing them. But I think where we really succeeded was the fact that it was built upon existing infrastructure. So there was already a long-standing partnership at the university where we started with this clinic that was in rural South Africa. So residents had been going there for, correct me if I'm wrong, Dr. Porterfield, but I think 10 years by the time we had gone. And so finding infrastructure that's already in place, partnerships and relationships that have already been established, where there is some level of trust and understanding about who people are, where they're coming from. It's a little bit of a vouching for you. And the truth is that our connection with ENT was facilitated by the primary South African doctor who provided care in this community, happened to meet one of the ENT providers in Pietermaritzburg. So that was sort of along the journey, who happened to be one of the organizing faculty for the national meeting the first year we went, who happened to reach out to us, finding out that we were coming, invited us to give a talk. And, and our initial conversation was sort of like mildly distrustful, to be honest. It was like, you're doing this very odd project. I don't think that culturing ears in rural South Africa is going to work. We're not really sure why you're here, but we persisted and made other connections, made friendships, made those personal interactions that then, I don't even know how many years we're in now, 7, 8 years later, there's been that additional trust built. And so it's amazing how much infrastructure is really already present in a lot of different institutions. We are by no means unique in the fact that we engage in institutional level partnerships. I think we've done a pretty good job at it, but we're not unique in that. And there are other departments, regardless of your specialty or interest, that probably already have a connection, whether it's a personal one, whether there's an ongoing relationship, et cetera. And I think that was really critical in engaging in this partnership and it getting off the ground, ultimately in a very organic fashion. As far as funding, that is tricky. So our secretaries literally had a bake sale to fund some of our early projects. We wrote some very small grants that sort of added up. And then you just get some very passionate people who are willing to dip into their own funds to travel, et cetera, so that it's not a financial burden for trainees, but most US faculty are in a position where they can at least get a plane ticket over there, and then you sort out accommodations, et cetera. So it's often done on a shoestring budget. But I think that part of what we found was in engaging in research allowed us to do small pilot projects, which had small funding pots of money, with the ultimate goal of doing larger projects that can support sort of an exchange in a larger, broader sense.
And just to build on that, I think, we did engage an existing infrastructure early on. And I think that is always a fantastic place to start. Look at where things have been working for some period of time. But I think one of the key lessons is, look outside of the partnership and keep an open mind, ask the questions that are bothering you, when you're at site, or, when you're having these discussions. And I think, having those discussions with the local providers is really key. And that local meaning both ways, that we should bring partners to University of Kentucky, University of South Florida, and having those open and frank discussions about, where, what the pathways are for care, what is the problems that are, plaguing these communities. And I think that really was a lesson of success here, is that, having, extending outside of the existing framework and talking directly with, the ENT providers at that conference and at the University of KwaZulu-Natal has really helped to build this program.
Yeah. And I know that Dr. Sibiya has also leaned on some existing infrastructure and other funding mechanisms in South Africa. So it's amazing. I'm always astonished by what you accomplish, but I'm sure people would love to hear about sort of your extent of making this all work from your end.
Yeah, look, I think funding is always going to be a problem. And really, for me, it's just been a matter of giving people an opportunity to help where they can. And so I regularly harass our private companies saying, you have this machine that you already have in the country for teaching and training purposes. I need it to be able to do X, Y, Z. All it'll cost you is transportation to me, and I will write you a little thank you letter that you can publish. And they've been really great at being able to provide that kind of support. I think there are a lot more people looking to be able to help than we often think. It's a lot more difficult to get cash and money, but very little. Well, let me not say very little. I think there is a lot that we can do with just support in terms of equipment, in terms of space, in terms of time, in terms of venue availability, that a lot of companies will be able to, are willing to provide. We've had people donate, time with a microscope, flying in microscopes from other parts of the world, for use for us when a microscope in a rural hospital had broken down and we needed to be able to do ear surgeries, and it looks good for them, but it helps us get what we need done, because our procurement processes in those units take a lot of time. You can look to up to a year just waiting for a replacement microscope. And so where you can leverage your relationships with our corporate sponsors and partners, that really makes a huge difference. And they often do have budgets for teaching and training and education. And it's just about, forming again those relationships with reps to say, and we actually have this need, and proving to them that you're going to do with the donation what they would like you to do.
It's amazing the power of a thank you note, right?
Yeah.
Just always be polite and say, I am happy to give you props for doing this. And it's amazing how many people truly do just want to help. Cash is always hard, right? No one wants to write a check and it just sort of disappears into the ether. But there's an amazing number of ways, as you said, to find support in other ways, whether it's people donating time, donating space, donating of their skill set, et cetera, that really is a phenomenal outpouring that we've gotten to experience.
Just a note of caution on that, obviously, is always being conscious of perverse incentives, and conflicts of interest. And that's something that I've tried to take really seriously. And so often when we do enter into these donation systems with a private sponsor, I'll have them write up a letter and say, listen, you're giving this to me for 3 months because mine is broken, but I want it on record that does not mean I'm buying yours when I finally get mine. Because you don't want to perverse the system. You don't people looking to support you for their own material gain necessarily. Obviously, there are nuances to that, but I think it's important that even in our smallest platforms, we do our best to remain kind of ethical and above board with these relationships.
We've learned a lot of lessons with the changes that have been brought about by COVID-19, and sort of building on this discussion of, what are ways that you can create these partnerships in, unique ways where there might not be a lot of funding. What sort of ways can we pivot and develop these programs in sort of the post-COVID era? And building on that, sort of where do you see the future of this partnership?
I think that's a really great question. I must be honest. I think COVID has been great in teaching us that we can connect in ways beyond the interpersonal, in face-to-face. But I still like to see people. I still like to have a cup of coffee and give somebody a hug if I've known them for a long time. And so I think for all the lessons learned from COVID about how we can connect, how we can, still remain engaged. I do think that beyond COVID, the need will remain for people to congregate, to meet, to have those moments of kind of collective experience within the same space. So I'm really looking forward to being able to bring even that back. It may not happen in the same way, may not happen tomorrow, but we really hope that we'll be able to bring at least some of that back. But even within that, there has obviously been a lot that we've learned from the COVID experience. Meetings like this would never have been seen as feasible without me probably having to travel across to the US to be able to participate in this presentation. And so I think that in itself has been really great, the ability to be able to connect more people more easily from different settings without sometimes a very real constraint of funding to be able to travel. So that's been something really exciting for me to be able to see happening. And I think it's something I'd really like to see moving forward. What it also offers us is an ability to meet with each other on less formal platforms, in our internal departmental research platforms, for example, where we can have intimate conversations at levels that aren't quite this exposed, where there can be an element of vulnerability, even for our most junior staff, to be able to learn and grow and share with each other. So that's also something that I think we're looking to explore.
There was a question specifically about recruiting women in surgery and what's required in terms of mentorship. And sorry, Dr. Toman, I didn't know if you wanted to add something before I switched.
I was just going to echo what Dr. Sibiya said. I think that, basing our exchange on the 3 pillars of education, research, and clinical care gave us the ability to pivot away from maybe direct education sharing, outreaches, obviously no direct clinical care from teams from separate countries, et cetera, but really allowed us to hone in on some of our research questions. And some of us had a little extra time occasionally, seems to have all disappeared, but to sort of think about, and as we were, canceled all elective surgeries, et cetera, to, you could re-engage on some research focused things. So that's been a great thing. But I absolutely echo Dr. Sibiya that the in-person relationship and the ability to just share a cup of coffee and a hug with an old friend is, I'm very much looking forward to that.
So to pivot slightly, the 2 of you are truly remarkable talents and passionate individuals. And we hope that there are many more like you in the training pipeline. So I also know that recruiting and mentoring women in surgery is a passion for both of you. But we did have a question specifically about how do you go about supporting recruitment of women in surgery? How do you support them? What can you do in terms of mentorship?
So I'll take that one for you. So
you can start it off. Go for it.
Yeah, I think there are a number of levels in terms of achieving kind of transformation within these spaces. The one is mandates, and that sounds really horrible. I know there's a lot of negativity around mandates at the moment, but sometimes you actually have to compel people to when systems are inherently exclusive, when there is an inherent kind of, I choose people who are like me, and I continue to be with people who are like me and think like me and talk like me, it is really hard to force to change that unless you actually prescribe it in some way, shape, or form. And so for me, that can never be forgotten. The fact that sometimes you have to actually have that structurally mandated. So for example, within our recruitment processes, we actually have a tiered system where we look at what your current profile is within your units in terms of representation across genders. And if you have a unit that is skewed one way, you will be compelled in terms of scoring systems to add scores for somebody being a woman. Now, that doesn't mean they bypass all the normal requirements. They still need to go through the entry-level stuff, write the primary examinations that might be required, do the rotations, meet the minimum requirements of cases, and all of those usual prescripts still need to be met. And once those have been met, you then need to target how your kind of legislation around your hiring practices. So that's one end of it. The other end of it is obviously creating a space where you are seen. So representation matters. So when people see somebody like them in a space, they see it as possible for themselves as well. And that means that we actually have to go out. So I get involved at undergraduate level. I go into high schools and say, this is who I am and what I do, not as often now with COVID as I used to, but that really is part of it. And the pain of mentorship, I don't know if it really is a pain, is that they say you have to mentor 10 people for one person to follow you. And so creating systems and communities where people can engage with you. And look, I'd love to recruit more women into ENT, but I'm just as happy if they're going into orthopedics once they've had time to meet me, because that also needs to change, And they might find that ENT is not the right fit for them, but maybe orthopedics is. And so all of those opportunities to just have conversations with people, it means you have to open yourself up and be a little bit vulnerable and tell people that there were times that I struggled, that I was in a ward round and I felt like crying because that's the she in me. And I had to in and walk away. But also there were times when the team walked away and asked me to clean up the table. And I said, no, I have the same degree as you.
Yeah, I think that there's a lot of different elements, and I think it's something that we struggle with, is how do you juggle all of these different competing interests, desires. But I think that one of the things that really spoke to me about what you said, Dr. Sibiya, is just seeing someone doing what you do or what you think you want to do, and just standing up and being a leader. So, I don't necessarily do anything different in my job every day, but I'm thrilled when I get a message from a young female medical student who says, I didn't know your field existed, and I'm so excited to learn about what it is you do. Now, they may not become an ENT, they may not become a facial plastics person, but my goal is that they feel then hopefully empowered to pursue whatever goal it is they want to do. And I always tell people this, sort of regardless of gender, when it comes to mentoring, is, find something you want to do that you are passionate about. Don't pick a training pathway because it seems shorter, easier, and you just want to get it over with. If you choose one of the longer, harder ones, make sure you really love it. But I remember this was actually one of the most formative conversations I had that maybe transcends gender, but she happened to be a woman anesthesia resident. There's nothing wrong with anesthesia, by the way. I considered doing it. But she said, I said, oh, why did you go into anesthesia? Because I was considering anesthesia at the time. She said, well, I just wanted a shorter training and I wanted to get out. And I was like, and she was one of the most miserable people I'd ever seen. And I was like, what? Even if a training is 2 years longer, 2 years for the rest of your life to be great, that really spoke to me. But I think it really helps when you see other people who have taken those sometimes really difficult steps. I have myself benefited from the modeling that I got to see some of my faculty members engage as young, energetic, outspoken advocates for education, regardless of gender, but they were women doing it. And I found that an incredibly powerful thing. And so I think that there continues to be a dearth in mentorship, and mentorship can mean different things to different people. It doesn't mean that the person that you engage with is going to, tell you everything is okay and give you a hug every time you make a mistake, right? And I think that's often one of the most difficult things as a woman being a mentor, is you sort of expect someone's going to mother you. And that's not actually good mentorship. But we also need to be aware of those own cultural biases that we have, where I'm maybe not going to yell at you with profanity like some of my male colleagues might, but I'm still going to tell you when you messed up, because that's my job as a mentor, right? And so I think that one of the struggles has been that oftentimes women struggle in finding mentorship because, one, maybe the people you're trying to get mentorship from didn't get good mentorship, and so they don't know how to be a mentor, right? It's like being a parent. There's no actual good guideline, I'm told. But it's also that, you have a cultural bias that you sort of want someone to be warm and fuzzy. And I try to be warm and fuzzy. I think I am some of the time. But sometimes you need someone who's going to kick you in the rear end. And you need to appreciate the fact that in order to succeed, sometimes you need someone to light a fire under you. And so I think that examining our own biases around mentorship is critical in engaging in a very fruitful mentoring experience.
I think
and if I can just add something to that, if you'll allow me.
Yes.
One of the other things about changing these landscapes, they say that transformation is about, and diversity is about getting somebody in the room, having more people of different faces and genders in a room. But inclusivity is actually hearing them when they speak. And one of the things that surgery in particular is traditionally known for is being a very unfriendly environment. The long working hours, the frustrations, the testosterone-driven anger and yelling. And some of what we need to do is actually look at some of those norms within our discipline and say, what is it in here that actually is about surgery and what is actually not, that needs to be removed to create an environment that is more inclusive. And some of those things are really small. So for example, if you have a woman on your team who's just had a baby and wants to breastfeed, do you have space and time for her to be able to go and pup? That's a very small ask, but makes a big difference in terms of allowing women who have made many different life choices to be included within your space. Having a child doesn't make her less of a surgeon. But if you preclude her from that environment because you're not allowing her to fulfill her other objectives and other roles, you've then lost potentially somebody that's really great.
One of the most
What time do you have your academic meetings? Is it before after school drop-off time?
Right.
So some real realities that we can tweak in how we create these environments.
One of the most remarkable things about this collaboration really has been sort of the depth and breadth that we have seen. And so we've tackled everything from, hearing health and head and neck cancer screening and mentorship and research. The symposium that you both ran on women in medicine and surgery as part of this collaboration was really profound. And I think bringing, multiple providers into a room for this discussion from all over the world and seeing how similar the challenges we all face were, I think was very profound. And on that, sort of in that direction, I think, understanding how similar challenges actually are and how powerful the global health partnerships can be to tackling those problems. So we are facing a lot of the same issues in rural America and in marginalized populations in the United States that are faced in rural South Africa. And as an HIV infectious disease provider, I have learned tremendous lessons from my colleagues in South Africa about how to provide outstanding outreach care in ways that we don't do a great job of in the United States. And so one of the real benefits and privileges of this partnership has been that bilateral exchange of ideas and understanding and tackling things together. And I invite the audience, we've got just about a minute left, but to really learn from this example of how do you take the expertise from around the world and tackle problems that we're all facing together. I think it all starts with a conversation and being very open to those conversations, reaching out, touching base, and avoiding that traditional sort of global health partnership of a north-south partnership where one party comes in to fix another country. I think is very clearly not a strategy that works, but really diving deep into these conversations and finding where are the similarities and where's the shared expertise. So with that, I just wanted to thank both of you for the incredible presentation, for the remarkable example of a global health partnership, and I'm excited to see where things go moving forward.
Well, it's been such a privilege and a pleasure. Thank you so much.
Yes, definitely. Yeah, thank you very much for having me. It's we could have these conversations all evening, but thank you very much for having me. It's been a pleasure.
And our thanks to the Global Health Conversation Series here at University of South Florida. I'm certain that any additional questions could be directed to their office, and we'll get that to the presentation, to the presenters, and we'd be happy to entertain future discussions. But our thanks to everyone again.